This is Pop Health Week on Healthcare Now Radio. I'm Gregg Masters, your co-host, executive producer, and the managing director at Health Innovation Media, where we curate content for the transformational imperative. Joining me in a virtual studio is co-founder and principal co-host Fred Goldstein. Fred also wears the hat of president at Accountable Health, LLC. Pop Health Week is your go-to platform for peer-to-peer conversation with industry leaders, innovators, and ecosystem stakeholders, including payers, providers, patients, vendors, and the regulatory communities. We come together to swap the best ideas and practices in population health management. Connect with us via www.popupstudio.productions or drop me a direct message on Twitter via @GreggMastersMPH, and that is Gregg with 2 G's. You can reach Fred direct via Twitter at FSGoldstein or on the web at www.accountablehealthllc.com. On this episode of Pop Health Week, we feature managed care industry veteran Cliff Frank, president at Healthcare Management Solutions. Cliff has been involved in managed healthcare programs for 30 plus years, working for payers, providers, hospitals, IPAs, PHOs, and clinically integrated networks, or CINs. We discuss the state of the managed care industry and its latest iterations of value-based healthcare, including how recent CMS risk adjustment updates will likely impact the Medicare Advantage program. Throughout his career, Cliff's focus has been on reducing waste and enhancing quality for the benefit of patient care. Creating clinical and financial alignment among providers and payers has been a central theme to his professional work across a variety of settings and organizations. Cliff provides leadership to CINs, operating shared savings relationships with payers and Medicare, and routinely consults to organizations on their managed care contracts, strategy, preparation for risk transfer, and innovative provider-payer partnerships. And with that introduction, Fred, the mic is yours.
Thanks so much, Gregg. And Cliff, welcome to Pop Health Week.
Thanks, Fred. Great to be back.
Pleasure to get you back on. We'll probably get into a little bit of Cliff's confab coming up because it was a fantastic one last year and you got one coming up this year. But first, why don't you give our audience a little sense of your background?
I'm a managed care aficionado of 40 years, sad to say. I've run medical groups, I've run health plans, I've run networks, ACOs, PHOs, IPAs, anything with 3 letters. And I've been yelled at by everybody, so it don't matter anymore.
You sure have. You sure have. You've got the battle scars to show it. And I was thinking about that. I think we met 30 years ago.
Yeah, Healthcare USA. That's right.
Yeah. So what are you doing now? Like right now?
So I'm having some fun. I'm still running an ACO for a health system up in South Jersey. And I do all their managed care and then the ACO for about 45,000 lives, Medicare, commercial, and Medicaid. And then I'm helping shut down a health plan in Virginia. It is getting to be a more common experience. I think there are going to be a lot more little provider-sponsored health plans that kind of run out of runway. And I think this shift to version 28 from version 24 in Medicare Advantage and the risk scores is a big deal to them because now you have to manage care instead of manage risk scores. And that's a lot harder to do, especially for a provider-sponsored plan that doesn't want to make its doctors real mad at the parent. So I'm doing that and then helping some young companies kind of figure out how to spell managed care, let alone, get acquainted with it. So it's fun. I'm always working in that space between payer and provider, trying to find commonality around clinical and financial outcomes so that everybody can benefit by aligning with the patient and what they need. And that's maybe a little old-fashioned, but I still think it works, or it can.
So you talked a little bit about these risk score adjustment things. Can you get into that a little bit more? What actually the changes are? So some of our audience maybe who hasn't been involved with that can get a sense.
So way back when, 30 years ago, when we were kind of new in this, Medicare just paid one rate based on the average area per capita cost, the AAPCC. per county. So that's what you got as a plan. And if you got healthy people, great. If you got sick people, uh-oh. So a lot of health plans would do things like put the enrollment office on the third floor and turn off the elevator and figure out if you could make your way to the enrollment office, they were happy to have you. If you needed some assistance, oh well. So Medicare got wind of that and said, no, that's not going to work. So they created these risk adjustment scores that were a means of trying to make things fairer. So that if I had a bunch of healthy people in my health plan, as measured by the presence or absence of certain diagnoses, then I got less money. And if I had a lot more of those sicker patients, the diagnoses would risk adjust, and I would get more money as the Medicare health plan. Well, it turns out that some health plans got really good at identifying diagnosis codes that would risk adjust and making sure that more and more patients had those diagnosis codes. So if you were a morbidly obese diabetic, you got an extra bump than if you were just a regular diabetic. I mean, the plan did. So eventually, the Medicare started introducing kind of risk adjustment creep countermeasures, including just kind of raising the bar 3 or 4% every year just to kind of neutralize risk score creep, kind of like charge neutralization on hospital charges. Well, they were doing the same thing on risk scores. Well, Congress finally started turning up the heat a lot. And so CMS came out with a new risk score version 28.
And before that, weren't they doing audits of those risk scores?
Oh yeah. So CMS has health plans have done a lot of kind of interesting things. They would actually send teams of nurse practitioners into patients' homes.
I knew some of those companies.
That's right. So they would take a full health history, and they would find things, and then they would submit those to Medicare. Well, eventually Medicare said, no, it's got to be certified by a physician. So then they would take those same exams, send them to the physician would sign off. Yes, these are the right diagnoses. Boom. So they still would play those games. Well, eventually CMS decided to do some audits of those, and they found that there was a lot of kind of discrepancies, shall we say, similar to maybe the old Columbia health system, that we otherwise would refer to as fraud, but since he's an incumbent, we don't do that. Those discrepancies ended up with some $100 million settlements with United, Anna, and some of the other characters. But that really wasn't enough of a deterrent. That was just a kind of a cost of doing business. So now CMS has really changed the game. And version 28, as opposed to version 24, I don't know what happened to 25, 26, and 27, but version 28 now is the new risk score methodology, and it risks adjusts on about 1/3 less codes, maybe more, maybe of a bigger reduction, but it's only being implemented 1/3 each year. So the full impact of this risk adjustment hasn't been felt yet, only a little bit, but already the Wall Street view of Medicare Advantage has turned decidedly neutral to maybe negative, as opposed to table poundingly enthusiastic. So it's coming, and it's going to be a 3-year painful process. And those entities that are globally capitated on a percent of premium basis, doctor groups or Oak Street Medical or One Medical,
is that right?
Yeah. Those Iora, those kind of companies, they're going to have the same problem in terms of the premiums aren't going up so fast, so they're going to have some compression in their rate. So they're going to have to manage care more effectively as well.
Yeah, I think about this from a population health perspective, and it's just a classic. You want to be appropriately reimbursed for the risk of the population that you have. But through the risk scores, maybe some of them played a little bit, identified risks that didn't exist or things like that, so they were getting extra. Others, now they've made that tougher to do. But what you're telling me is at the end of the day now, these people actually have to do some population health and try to manage the care of the individuals.
Yeah, I'm not sure it's a bad thing in all
Right.
in all. I think the principle remains sound that those with higher risk ought to get more money, but they should
Hmm.
earn it, not just be given it to them. So the other thing that's happening parallel with this is that CMS is now playing with indices of health equity. And through ACO Reach and some other programs, they are trying now to pay entities that are taking these risks more money to address classically underserved populations. And so it's another way of looking at population risk in aggregate as opposed to case by case by case. So I think you're going to see some new efforts in looking at social determinants and other barriers to care as far as kind of being either reimbursable or bonusable from CMS that have traditionally been not addressed. So some of the supplemental benefits like free groceries or gym memberships or some of those kinds of things may go away as we move forward because the Medicare Advantage plans have to cut back some things to pay for their declining premiums, but they may also add other services targeted at these specific populations so they can enroll and pick up some bonuses through those
Hmm.
mechanisms.
So theoretically, at some point in the future, we should see a reduction in the disparities that we see in healthcare by a focus more on some of these other issues. That's sort of the goal.
Theoretically, and one thing that's different about Medicare Advantage than it is about Medicaid or commercial is the persistence of this business with a particular health plan is about 95%. So you die or you move, but otherwise you pretty well stay with the health plan year after year after year, which means that those health plans can make longitudinal investments in the health of a population that they can't if in a commercial population where the persistence is only 50 or 60% and there's tremendous member turnover. So I think this opens the door to some really good things over time. It's a question of kind of how short-sighted or short-term focused are the health plans. And I think there's differences. Humana has been more longer term focused on disparate populations, and United has not. But those that could change certainly.
It's interesting you mentioned that because I'm thinking about both Humana and United, huge employers of physicians have subcapitated contracts with physician groups they own. We're
Yep.
seeing the change. I think it was Cigna that announced they're getting out of MA. Is that
Yeah,
right?
sold it to Blue Cross of Illinois.
So is it because there are differences in strategies? I mean, I don't know that Cigna was actually out there acquiring physicians, were they?
They have gone down that road a little bit. It's not a core strategy at this point for them. It's they're dabbling. But that's Cigna's way. They dabble in a lot of stuff. Express Scripts was kind of their big, jump in the deep end of the pool. But everything
Hmm.
else, they kind of, they are not regionally strong. They are thin, but they're broad.
Hmm.
Whereas Humana and Blue Cross and United are somewhat more deep in any given market that they
Hmm.
enter.
And where does CVS Aetna fit into that?
Well, they've got a problem right now. It's kind of funny. They're another bonus program is the Medicare Stars. And
Right.
if you're a 4 or 5 star plan, you get like a 5% premium increase. Well, Aetna has done such a lousy job of managing patient satisfaction and provider satisfaction that they lost their 4 stars. So they lost a whole lot of money. Wall Street was not happy about that at all because I mean that's a big whack, millions and millions and millions of dollars of lost revenue. So they
That's
are trying
reportable.
that. Yeah, that's right. And so they are trying now to kind of restar themselves. But in so doing, they also for 24 underbid their costs. So they are growing like half a million. They added like half a million members, but at rates which are too low. So in other words, they bought the business by enriching the benefit design. So they are going to again lose a bunch of money and they'll still be a 3-star plan because it takes a couple of years to change from 3 stars to 4 stars. And so they're going to be in trouble for a while.
Mhm.
Plus, they can't keep their CVS stores adequately staffed with pharmacists, so they're having, shutdowns and walkouts and all that. I mean, they've got a bunch of issues to deal with.
Just tuning in to Pop Health Week, we're in the company of managed care industry veteran Cliff Frank, president at Healthcare Management Solutions. We're discussing the state of the managed care industry and its latest iterations of value-based healthcare operators, including how recent phased updates to CMS risk adjustments will likely impact Medicare Advantage operators. Stay tuned for the rest of the story.
We sort of hammered the MA market. You were operating an ACO. You're now an ACO REACH. What's that looking like?
It's getting harder. It's getting harder to make your bonus, whether it's Medicare, commercial, or Medicaid. And 2020 kind of wrecked everything because most of us in the ACO world made bonus, and we made big bonus. So we were like, our ACO is owned by a hospital. So we were a counter-cyclical investment because, fee for service was down, bonus was up, yippee, we're good. But then, when you have a good year, that kind of resets the bar for the next, not the next year, but the next 3 years. So, because it's a moving average in most cases of the last 3 years. So we have been, and a lot of other ACOs have been kind of climbing that hill, and it's been a challenge. Going forward, what's nice about the Medicare REACH program is there is no minimum savings rate. So unlike MSSP, you had to save at least 3 or 4%. So it's not a statistical fluke that you got bonus. And for 1 year, maybe 2, we saved enough, but not enough we saved money, but not enough to overcome that minimum savings rate. So we didn't get bonus for 22. For 23, we may have that same problem. For Medicare REACH, we won't have that, at least that problem, because that's gone away.
Now, one of the things I know you've talked about, in particular, in the class I teach, was your effort to improve your quality scores at the ACO. Can you talk some about that and some of the work you did and the results you've seen?
Yeah. So it would be nice if there was an immediate correlation between the quality scores and quality. There may be a long-term correlation. In other words, it's good to get mammograms, good to get colonoscopies and all that. But I mean, that prevents something, way down the road. But we have spent a lot of effort looking at care gaps and helping doctors close the care gaps. We can't close them ourselves as in the ACO, but we can nominate patients that need love and attention by the doctor to come in, get your HbA1c, your blood pressure, whatever else is missing. And so we've invested in some technology and some people to make that happen. And the doctors in our ACO, have actually let us into their EMR as if we were an employee. So we have read capabilities. We don't have write capabilities. So we can look and see, oh, there was a blood pressure, but it was over the limit. So let's bring the patient back in and see if they're now better controlled. We do that a lot, and we get really good cooperation because we're kind of not trying to mess with their workflows. We're simply a nag service. Please do this. Please bring this patient in. Please do this. And they are responsive. There are other ACO companies that really go to the other extreme, where they'll just rip up their existing workflows and say, give them a care manager, give them a pharmacist, give them a social worker, and say, okay, now you're going to do things this way. And frankly, in many settings, that's much more effective. We have the perversity that our owner in our ACO is a hospital, so they really kind of want to make sure that we crush utilization in those other hospitals, but leave their hospital alone. So it's kind of a delicate balance of we don't want to make the CFO go crazy, but we do want to, but if we can save 4 or 5 or 6% a year, that's good. So
Mhm.
that's what we try to do.
And can you discuss the issue of leakage and how that sort of relates to what you just mentioned with the
Oh
hospital
yeah.
beds?
So in a physician-owned ACO, this is less of an issue, but in a hospital-owned ACO, it's a big deal because often the hospital owns a medical group. The medical group's job is to feed the hospital for procedures, and the hospital then bills fee for service, heads in beds, the whole deal. So we come along and we say, well, we're gonna crank down on utilization. And the hospital CFO looks at me sideways and says, why is this a good deal for me? Well, you get savings. Yeah, the savings only amount to 25% of the dollars I lost through revenue, is what the CFO say. So we have to kind of figure out how to kind of make that right. And so most ACOs have a problem with patients going outside their narrow network. So that's called leakage. So in Medicare, patients can go anywhere to anybody who's a contracting Medicare physician. Same thing in commercial HMOs or commercial PPOs. So the network that the patient faces is really big. The network that our ACO doctors face is pretty tight. So we will try and send the patients to the narrow network, and the patients may do one of three things. One is they go to the recommended doctor. The second thing is they go somewhere else because they've had an experience that's positive. It's geographically more proximate to their residence. It's Tuesday. I mean, who knows? And the third is the patients may just self-refer to the specialist and not even tell the primary care doc that they went and it's the wrong specialist. It might even be the wrong specialty, but they're just determined to go. So we in our ACO have a leakage rate which is 60%. Now, some of that is for services we don't do. We don't do open heart. We don't do craniotomies. We don't do heavy duty cancer. So 30% was going to leak, but another 30% is just people being stubborn or bound to go somewhere else for whatever reason. So that's high. There are lots of ACOs that have 40 to 50% leakage rates. So we're at the high end of that, but not crazy high end. And so the challenge is how to kind of help that doctor-patient relationship develop a richer, meaningful dimension rather than just being a transaction. Give me a script, I'm out of here. So we continually are working on that, but we haven't cracked that code yet. Mm-hmm. I don't know anybody who has.
Got it. Fascinating issue. They can go wherever they want, and clearly
and they do.
That's
right.
So to sort of close this thing out, a few minutes left, let's talk about Cliff's confabs or the raucous caucus. And I know you got one coming up. So tell us about that.
So many years ago, I don't know, 20 of my favorite people got together to talk about something. Back then I forget what it was, but we met in Baltimore and had a good time. It was killing a day talking. I think this was about clinical consistency or inconsistencies and unexplained variation and how to kind of address that. And then every year after that, I've had one of these confabs, and it's kind of grown in both numbers and sophistication and enthusiasm. And so a few years ago, I did one, and I passed out two items for all the participants. One was a whirligig, so you swing it around and it makes a kind of a motor sound, and the other one was a plastic hammer that squeaked. So you hit the hammer and it squeaked. And the idea was, well, if you agree with whatever the speaker is saying, you hit the whirligig, and if you disagree, you hit the hammer. And boy, we had some enthusiastic kids, just pounding on their hammers. It was great. So it really is designed to be a conference of professionals in the field, doctors, consultants, actuaries, lawyers, all different kinds of people. But the common thread is that I know them and like them and respect them, and we get together and have a food fight about a particular topic. This year, it's about private equity in healthcare. Is that good? Is it bad? Is it maybe some combination of the two? So we're going to have some speakers who are private equity or live with private equity or are private equity keen observers, and we'll have some kind of very interesting stories on all sides of that and some very strongly held opinions.
Yeah, it's fantastic. I'm looking forward to attending. I assume this year, if I pass the Raucous Caucus, I'll get another BS and BS from you.
You will. You'll get a master's degree, actually.
Oh, I'll get a master's this time, an MS in BS.
An MS in BS. That's right.
That'll be fantastic. Really looking forward to it. Well, thanks so much, Cliff, for joining us and providing us with your incredible insights on Medicare Advantage, ACOs, what's going on. Love to get you back on and talk some more about some other topics as well.
Anytime, Fred. It's always good to see you.
And back to you, Gregg.
And there you have it, folks. That is a wrap for today's broadcast. We want to extend appreciation to our worldwide listeners for tuning in, and deep gratitude to managed care industry veteran Cliff Frank, president at Healthcare Management Solutions, for sharing his insights today. Do keep up with Cliff's work on the web via www.clifffrank.com. And if you find our work here at PopHealth Week engaging, please show us your support. Do give us a thumbs up on your favorite podcast platform, share it with your colleagues, and subscribe to ensure you don't miss out on future episodes. We're live on Healthcare Now Radio weekdays at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern, and for our friends on the West Coast, that's 2:30 a.m., 10:30 a.m., and 6:30 p.m. Pacific. From all of us at PopHealth Week, Fred Goldstein and yours truly, Gregg Masters, we urge you to stay safe and stay tuned, and until next time, fare thee well.